Welcome to the 15th webinar in the MGHS Institute Interprofessional Webinar Series. My name is Ebtisam Ahmad. I'm an Associate Clinical Professor at St. John's University, College of Pharmacy, and I'm the Director of Pharmacy Internship for the MGHS Institute for Innovation in Palliative Care. I have nothing to disclose. Today's webinar will be about the management of anorexia and cachexia in patients in palliative care populations. My objective for today's talk is to discuss the prevalence and significance of anorexia and cachexia in patients receiving palliative care. We will learn about the clinical features and some of the assessment tools that could be used for the management of cachexia, especially in the palliative care population. We will also discuss some of the treatment options, including non-pharmacological as well as pharmacological options for patients who are cachectic while they are receiving palliative care. And we will talk about efficacy of these drugs, and we will talk about the impact on quality of life. Cachexia is hypermetabolic. It's defined as a multifactorial syndrome. It's a hypermetabolic condition characterized by loss of skeletal muscle with or without loss of fat. So you could have patients who are losing fat, but on the same time not losing fat. It could happen either way, but the main hallmark of cachexia, the patients are losing skeletal muscle mass. Oftentimes, it's not reversible because it's due to an underlying cause that's irreversible, so it could be in cancer patients we see it. Very often we see it also in COPD, we see it in CHF, we see it in heart failure. Oftentimes, it's a progressive functional impairment, results in impacting quality of life of the patients. It's usually diagnosed when patients have weight loss more than 5% of pre-illness weight in the previous 2 to 6 months. So if you have patients that have an unexplained weight loss, they're not trying to lose weight, they're losing a lot of muscle skeletal mass, it's something to think about. Are these patients cachectic? And you should get an assessment for nutrition, and you should decide as far as treatment options what you're going to do for them. The negative impact from a pathophysiology standpoint, negative protein and energy could result in reduced food intake, which is anorexia, which is loss of appetite or loss of caloric intake. And it could also be a result of an abnormal metabolite, something that's happening in the body that's triggering the body to feel that sensation that I don't want to eat. I have loss of appetite, I don't want to drink, I don't want to eat, I'm not feeling hungry, and so on. When we look at the prevalence of cachexia in palliative care, it happens approximately in 70% of patients during the terminal course of disease. And when we break it down by what type of disease, it's pretty common in cancer patients, and about 85% of cancer patients, especially patients in advanced cancer, will have cachexia. It's pretty common in certain types of cancer versus others. It's common in gastric cancer, common in lung cancer, common in pancreatic cancer. They consider it to be one of the highest prevalence of weight loss. It is also a syndrome that you can see in patients who have AIDS or HIV with a prevalence of approximately 30%. It's also a syndrome that you see in patients with chronic obstructive pulmonary disease with a prevalence for up to 60%. And you can also see it in patients who have congestive heart failure with a prevalence of at least 20 to 30%. And it could also something that you can see in other illnesses as well. So you can see it in patients who have dementia, or patients who have tuberculosis, or patients who have malaria, or patients who have chronic kidney disease. So what causes cachexia? So there are two things that could be happening in here, and specifically I'm going to talk about cancer patients. So for example, when you have a patient that has pharyngeal cancer of some sort, and they have cachexia due to reduced food intake or secondary to dysphagia. Secondary could be due to the fact that they're getting chemotherapy, or it could be due to the fact, to the illness itself, that could result in anorexia. So as a result, you see loss of appetite and reduced caloric intake. Versus if you have someone who has also at the same time another patient who has small cell lung cancer, and they have severe B-type symptoms such as sweating and so on, they could be using a lot of symptoms that could result also in metabolic changes in these patients. So it could also result in reduced caloric intake, a reduced sensation of appetite or food, and so on. The phases of cachexia, it's divided into 3 categories. It starts with pre-cachexia, which is oftentimes partially reversible in the sense if you have someone who has a chronic condition, but it's not too severe, it's not too advanced yet, it didn't become too severe to the point that they're not eating or drinking anymore. That's something that we can think to reverse. That's a partially reversal. Versus if they have cachexia and as a disease, if you think about it, as the disease continues to progress, they're going to go from pre-cachexia to full-blown cachexia, then they're going to go to refractory cachexia, which at this point is considered to be irreversible in the sense there's not much that you can do for them. What you're going to try to do as much as you can is to improve the quality of life because the underlying cause is irreversible. So anytime that you have a disease that is irreversible, so for example advanced cancer, and you cannot do anything about it, there's no more treatment option as far as chemotherapy or radiation, these patients, if they develop cachexia, at this point it's irreversible. And our goals of care, which we really need to involve the caregivers and the family, and this is where interdisciplinary really by definition comes in, different members of the team, physicians, nurses, social workers, and so on are going to come and explain to the family, to the patients, to the caregivers what is really happening, especially when they see their loved one not eating anymore or not asking for food and losing muscle mass and so on. From a mechanism of action standpoint, what we see in large set of different transcription factors that's happening that could result in cachexia. It could be the immune system modulator. So you have a lot of pro-inflammatory cytokines such as interleukin-1, interleukin-6 that could be released that could result in anorexia, so loss of appetite, and it could full-blown develop into cachexia. What's also happening on the same time, especially in cancer patients, you have a tumor production that's involved that could also be stimulating certain things within the body that could cause a lot of metabolic abnormalities, results in protein loss, results in cachexia as well. So understanding the pathophysiology of cachexia can kind of really help us how to treat it as far as treatment, pharmacological treatment options. So it involves the immune system, it involves cytokines, it involves inflammation, so we're going to have to think about giving anti-inflammation drugs. It often involves like tumor products, so it could involve tumor necrosis factors, so we're going to think about these drugs as well as far as an option for these patients. And it could involve also metabolic abnormalities, so we're going to have to think about drugs that could play a role that comes to metabolic abnormalities as well. In addition to prognostic value and loss of muscle mass, cachexia is often associated with poor functional status. Due to the fact that patients are losing a lot of muscle tissues. It's highly correlated with decrease in concentration and alert and diminished by fatigue. Oftentimes these patients, and think about your patients that you see and every day to day, especially if they're cachectic, they complain of fatigue, they complain of weakness. It's also highly correlated with psychosocial outcomes such as anxiety, mood disturbance, depression, decreased sexual interest and enjoyment in life in general. It could also result in reducing in physical and mental ability and emotional activities. One of the biggest impacts on the quality of life, not only of the patients, but the caregivers and the family. Oftentimes, and this is validated in the literature, when we ask caregivers, how are they feeling that their loved ones are not eating or not drinking or not asking for food, oftentimes they do feel a lot of sense of loss of they feel helplessness, they feel they can't do anything for their loved one, they feel loss of dignity because they are not the one in control to decide what they can eat their loved ones or not. They feel a lot of sensation of guilt. They feel that they are starving their loved one. Meanwhile, we really need to explain and we really need to involve the family and explain to them that this is happening due to the fact that they have an advanced medical illness of some sort. They are not starving them. This is part of the normal course of the disease, that when the body starts to shut down, at some point, patients are not necessarily going to be asking for food. They're not necessarily going to be asking for things to drink and so on. So we really have to recognize the impact of caregivers. This is why social worker is very important, because they are the ones that see the patients on day-to-day. They are the one that deals with the caregivers. They can report back to the medical team and let us know what's happening with the patients and the caregivers and the family, so we can have these useful and meaningful discussion with the patients and the caregivers so everybody is on the same page and we can talk about the goals of care. The characteristics, some of the common findings or characteristics that you see in cachectic patients include anorexia. So these patients are not going to be asking for food. They're going to have lack of appetite, early satiety. They're going to say that they feel full right away. They could also complain of weakness or fatigue or lethargy. Sometimes also you can see biochemical alteration, such as anemia or inflammations or low albumin in these patients. And the hallmark that these patients are going to have unintended weight loss. So these are not people who are going on a diet or people trying to lose weight. No, these are patients who have chronic illness of some sort, and they have this unintentional weight loss for up to 10% of their body weight in a period of 6 months to 12 months, where they report this significant amount of weight loss without being intentionally trying to lose weight, and it's also associated with all the other symptoms that I mentioned, such as weakness, fatigue, tiredness, loss of appetite, and so on. All palliative care patients should be screened for nutritional status and weight loss. This is often done by a physician or a nurse practitioner or a nutritionist. And there's different types of assessment that we would want to assess in a patient that we think who might be cachectic due to their illness. Some of the objective measures, we're going to do assertive measurements of body weight. So we're going to ask patients a full history about their weight, about their dietary intake, what are they eating, what they're not eating, their oral intake as well, not just foods, as far as liquids and so on. We're going to be also asking them some subjective measures. So we're going to do a malnutrition assessment tools, and we're going to be discussing the different number of tools that you can use in practice to evaluate a patient who we might think might be cachectic. We can also do some laboratory measures, although they are not really rarely used in practice due to the fact that we rely more on subjective and we rely more on objective measures, such as like the patient's self-report, as I mentioned, and the nutrition assessment scale that we will be discussing. But you can look for laboratory measures such as like albumin or transferrin if you want to have an objective finding or laboratory measure of some sort. The diagnostic criteria for cachexia, the hallmark is the #1 thing that you want to find in these patients: an unintentional weight loss, more than 5% or 10%, more than 5% in 1 month, or more than 7.5% in 2 months, or more than 10% over a period of 6 months to 12 months. In addition to the unintentional weight loss, which is really the #1 thing that you want to find, in order to diagnose someone with cachexia, they have to have 3 out of those listed here in addition to the unintended weight loss. So they have to have a body mass index less than 20 on those aged less than 65 years old, or less than 22 on those aged more than 65 years old. Also, in addition, if patients have an albumin less than 3.5, that could help us in diagnosing patients who are cachectic. If patients have low fat, free mass, lowest 10%, if they have some evidence of cytokine access, such as an elevated C-reactive protein, and if they have any subjective or objective findings. So patients self-report, again, telling you that I'm fatigued, they have decreased muscle strength, so you're measuring the circumference in their, the upper arm or in their hips and so on. And patients also self-report telling you like they are not, they are fatigued, they are tired, they have lack of concentration, they are unable to interact with others, and so on. An international consensus group also came up with the recommendations that they recommended that 5 domains must be encompassed in order to make a better assessment for cachexia. We're going to be looking at the 5 domains include source depletions, muscle mass and strength, anorexia or reduced food intake, catabolic drivers, and functional and psychosocial effects. What's interesting about this international consensus, not only they looked for muscle mass loss and reduced food intake and caloric intake, they also looked for the impact of cachexia on quality of life. So the psychosocial effect of the patients, what's happening to the patients, are they able to interact with others, are they able to enjoy their life or so on, what is the impact of being a cachectic patient? So there are a number of different malnutrition assessment tools that are mainly developed to assess for malnutrition. The first tool that are valid, all these tools are validated in clinical practice. They could be used on any patients who might think might have cachexia, whether they have cancer patients or COPD or CHF or so on. The first scale is the patient-generated subjective global assessment scale, which is a well-established tool. It incorporates information from the patients, so we ask patients about their weight history, their food intake. We ask patients also about comorbid conditions, so we'd want to know if there is anything that might be resulting in the sensation of not wanting to eat, in addition to the fact that they have a chronic illness of some sort. Another assessment tool that could be used also is the mini nutritional assessment tool, or the malnutrition universal screening tool, or the simplified nutritional appetite questionnaire. All these tools has been universally, again, agreed upon as the best way to assess for malnutrition in a patient that you might think who might be cachectic. And one thing to mention is no single tool has been preferred one over the other. So you can really use any of them. They're all on the internet. You can access them for free, and you can develop a policy at your own practice that you could be using these tools to screen for patients. In practice also, we do use the patient subjective loss of appetite could also be used in with the numeric rating scale, such as the Edmund symptom assessment scale. Although the reliability of subjective assessment of appetite is debated, they're probably really the simplest way and the most practical measures, because you want to get the patient's reports. You want to ask your patients what is happening to them, right? So this is the Edmund scale that goes, it asks also about other symptoms. It asks about pain, it asks about feeling tired, it asks about nausea, it asks about depressive symptoms, drowsiness, and so on. And a scale also that incorporates the best appetite, for scale from 0 to 10, and this is a validated tool that could also be used that kind of give us an idea of the subjective loss of appetite in patients in palliative care patients who we think might be cachectic. The secondary nutrition impact symptom is another scale. It's a comprehensive assessment scale that could be used for patients who have cachexia or anorexia. It should also take in account what's interesting about that specific scale. It also takes into account other consequences of being cachectic, such as pain. So not only is it asking about your caloric intake or the underlying illness, in addition, it's asking patients about consequences: nausea, vomiting, constipation, pain, depression, xerostomia, mucositis, and so on, and looking at the impact of appetite and caloric intake, and as a result of that. This is also another validated tool that could be used for the assessment of cachexia. When we have a patient that we think also who might be cachectic, we want to look for other reasons that could result in cachexia. So we could look for some potential reversible causes or abnormalities. So if you have a patient that have hypothyroidism, but at the same time they have cancer, you have now two things that could be causing cachexia at the same time. So you want to screen these patients. Other also illnesses that include metabolic abnormalities, adrenal insufficiencies, and males hypogonadism is also could result in loss of appetite or fatigue or weakness. So you don't want to overshadow. You want to make sure that you look for other potential reversible cause that you could fix, and you could make the patients feel better and you increase their nutritional intake. Gastroparesis multifactorial is also it's a fairly common syndrome that we see in patients who are terminally ill, especially cancer patients. It can contribute to weight loss because of the inability to take insufficient calories. In cancer patients in particular, gastroparesis could be happening for multiple reasons. It could be due to chemo-induced autonomic dysfunctional, so it could be as a result of the chemotherapy itself. So for example, drugs like bevacizumab or sorafenib could result in weight loss. It could result in loss of appetite. It could be also due to other drugs that are on board. So in a cancer patients, oftentimes we treat patients' cancer pain with opioids or anticholinergic drugs for other indications. That could also result in weight loss, which could result in decreased loss of appetite, and so on. Tumor infiltrations as well as one of them, as well as results of paraneoplastic syndrome. So it takes a simple measure, just asking patients about gastroparesis, so if they feel like full right away after they eat, at screening their profile to look for chemotherapy that might be causing this as well, and so on, to try to really see if there's anything that I can fix, anything that's reversible before getting to the decision that now I reached to the point that there's nothing much I can do. I want to focus more on non-pharmacological and the pharmacological option for these patients. One of the things about cachexia, it's important to recognize as far as treatment, it's more silent compared to other symptoms like pain or dyspnea, because when you have a patient who has pain, oftentimes they will complain, they will scream, they will look agitated. Versus cachexia, it's not something that you can really hear from patient complaining about it, because oftentimes they don't feel that they're not hungry, they're not complaining about it, they don't even have any sensations of the fact that they want to eat or the fact that they are losing weight. It's something oftentimes is a silent symptom. We have to recognize it because, as I mentioned, it has a detrimental effect on the quality of life. It really affects the patients, it affects the caregivers, it affects the family. So we have to try as much as we can to recognize it and to offer treatment options for patients who might be cachectic. As far as treatment options and supportive care for these patients, pharmacotherapy is an option. However, it does provide minimum for these patients, especially in the presence of an irreversible condition. We're going to be talking about the different drugs that are options for these patients. What you can also do is you can do a lot of the social benefits of eating or dining with the family should be emphasized over the total caloric intake. So something that we really want to tell the family and bring them on board, and this is where social worker really play a big role here, that we want to explain to the family that it's not about how much they eat or drink, it's about that sensation, it's about having them enjoy preparing favorite foods for them. The pleasure of tasting the food should be emphasized over the total caloric intake. We want to also, if the patient is a candidate to receive nutritional supplements or food that's high nutrition such as eggs or such as liquid nutritions like Ensure or Glucerna, this is absolutely, you can do that as well. We want to make sure that these patients have good mouth care so they are not having, for example, if you have a patient that has using chronic steroids of some sort, and at the same time they have oral candida, that will definitely interfere with their ability to eat or drink. So you want to make sure that you're maintaining good oral hygiene, you're examining patient's profile to see if there are any drugs again on board. You want to try to provide a relaxing environment to eat for these patients as far as non-pharmacological options. And you want to avoid strong odors or heavy spices. These are things that could really aggravate the patient's stomach, could aggravate the smell, could trigger heartburn, could trigger them to be very anxious or agitated and so on. So you want to explain to the caregivers and the family the importance of addressing these non-pharmacological options. I remember in my practice, in my old practice and not currently at MGHS, we had a lot of patients who did not have the ability to completely ingest a meal or eat or digest a meal. So what we used to do for these patients, we let them chew on the food and then they would spit it out. That sensations of like ability to even like taste the food in their mouth brought them a lot of pleasure. So simple things that you can do for the patients that can bring them joy, that's also an option as far as what you can do for these patients. As far as treatment approach, we want to try to optimize treatment. So we want to look for any contributing factors and we want to try to eliminate them as much as we can. So if you have a patient that has chronic nausea of some sort or constipations or patients who have depressions, they could also result in significant anorexia. So we want to try to reverse those other contributing factors as much as we can. Patients and family, and this is very important, and this is really when we talk about goals of care and introducing an interdisciplinary team, bringing in the family, bringing in the caregiver, bringing in the physicians, the nurse, the social worker, and they should really understand that caloric intake does not reverse the underlying process. If you have a patient that has a chronic illness that's irreversible, we need to explain to the family that this is not an uncommon symptom. We're not letting your loved one starve. We're not letting them eat. We're not expediting their death. It's just a natural process of the end of life. It's a natural process at the end, or it's a natural process as the disease continues to progress, that oftentimes patients are not necessarily going to be asking for food, are not going to necessarily be asking for something to drink, and so on. So bringing the family on board is very, very, very important. So that loss of, they feel guilty or they feel like they're not helping them, it could ease that pressure and they could be able to enjoy the time with their loved ones. Treatment options, you also want to look for other causes. So you want to look for, this is a little acronym that you could remember, Meals on Wheels. So you're going to look for other causes that can cause anorexia. So medications, digoxin and theophylline could cause weight loss or can cause less of appetite. Emotional, so you want to get these patients evaluated by a psychologist as part of the team or by a therapist of some sort to see if they have depression, because that could be also correlated with the fact that they're not eating or they're not enjoying life or they're feeling weak or tired. You also want to see if they have late life paranoia, especially when patients have advanced medical illnesses and they know that their life is coming to an end of some sort. You want to see if they have any kind of swallowing disorders, oral problems again, if they have any kind of nosocomial infection like H. pylori. If patients, especially in elderly, if you want to evaluate if they have wandering or any dementia-related behavior. And you want to look for any other metabolic conditions that could result in anorexia as well. So things like hyperthyroidism or hypercalcemia or hypoadrenalism. And you want to see if they have any type also of an eating disorder in the past. Maybe these were patients at some point in their life before even becoming really medically ill with a chronic illness, they had an eating disorder of some sort. And you want to evaluate them also for gallstones that could also result in weight loss or loss of appetite. So important to, before you just make the diagnostic criterion, before you conclude, is to look for any other causes that could be aggravating the cachexia or making it worse. As far as pharmacological options, what we're going to be doing for these patients, so if you remember the first slide, we have the pathophysiology of cachexia involves the immune systems, involves your immune-mediated system. So you're going to try as much as you can to give things that inhibit inflammations or work by anti-inflammatory properties or tumor necrosis factors and so on. So megestrol acetate and glucocorticosteroids, mirtazapine is an option, verapamil, anabolic steroids, cyproheptadine, or others that we will be discussing. So the first drug is megestrol acetate, which is a synthetic derivative of progesterone. It acts as a progesterone as an anti-inflammatory and intrinsic androgen agent. It's FDA indicated for the treatment of anorexia or cachexia or unexplained significant weight loss in patients who have AIDS or HIV. And there are a number of trials also studied in patients who have cancer. One of the biggest things about Megace is to understand that it does, the symptomatic improvement that you see in weight loss may take time. So very important to explain to the patients and the caregivers or the family, because expectations again. This is not a drug that patients are going to take and then all of a sudden they're going to be asking for food, asking for drinks and so on. It does take time to work. It takes a couple of weeks, even up all the way to 12 weeks to see full benefit. Another important thing is also about Megace to mention as far as efficacy. The weight that you're going to see with Megace or megestrol, Megace is a brand name, or megestrol acetate, is mostly water weight and mostly fat weight. You're not necessarily gaining muscle weight, which is what we are losing in a cachectic patients. That's also very important to understand that they're not gaining muscle. They're not gaining muscle, they're mainly gaining water weight or some fat, adipose tissue weight, but there's no effect on the quality of life on lean body mass. So very important to keep that in mind when you're explaining the risk and the benefit to a family or a patient about efficacy of a drug. There are many randomized placebo-controlled studies that looked at Megace, not only in cancer patients or AIDS, it also looked at COPD, and it did show that it does increase appetite on some body weight. But again, no muscle weight, it's mainly water weight. It does have a dose-related effect when it comes to appetite and when it comes also to side effects. So to minimize the adverse effect, it's recommended to start at the lowest possible dose. So you would want to start at 160 milligrams per day and titrate every few weeks up to all the way to 1600 milligrams per day. Megestrol acetate does have a dose-limiting related side effect profile. We see now in the literature more cases of thromboembolic events. So you have to be careful when you have a patient that has a past medical history of a DVT or a past medical history of a PE, or a patient that has AFib and at the same time they are taking warfarin for some sort. This might not be the best option for these patients. It could also result in peripheral edema. So you have to be careful again if you have a patient that has congestive heart failure, or if you have patients that have any cardiac condition of some sort. It could also result in hyperglycemia. It could also result, chronic use could result also in hypertension, breakthrough bleeding, and increased liver enzyme. All these oftentimes are dose related, so the higher you go up on the dose, the more likely to see these side effects. So just something to keep in mind when you reach that point. It's been 12 weeks, the patient's not gaining any weight, the patients don't have that sensation of increased appetite. Maybe this is really not the best option for them, and have to think about other pharmacological options. Corticosteroids are well known to stimulate appetite. Most of the data that does exists with cancer patients. There was a systematic review done in 2005 that looked at 6 double-blind randomized control studies, looked at all the glucocorticosteroids, dexamethasone, prednisone, methylprednisolone in cancer patients, and they compared them to placebo. And what they concluded is that corticosteroids do improve appetite, they improve quality of life, but they have minimum beneficial effect. When it comes to weight, body weight, they do not increase body weight, and at the same time, their efficacy diminishes over time. So, and they do make patients, they are very useful in the sense of increasing appetite, but they are not necessarily going to see weight gain. And over time, when you keep using them, you're going to obviously worry about side effects profile, and you're also going to worry about their efficacy diminishes over time. One important thing also about the corticosteroids, there is no clearly defined dose. In clinical practice, we don't have enough evidence showing that dexamethasone is better than prednisone or is better than methylprednisolone. All of them could work, but it really does work depending on the dose. So in most of the studies, they were using prednisone to 20 milligrams to 40 milligrams per day, which is equivalent to approximately 3 milligrams or 4 milligrams of dexamethasone per day. And when compared to MAGACE, so now if you have a patient that you have who has cachexia, and you're thinking, should I give them corticosteroids or should I give them megestrol acetate? Megestrol acetate is much more money, is more costly compared to corticosteroids. However, besides taking cost consideration into account, how you're going to make this decision, it depends on how long does my patient have. If I have a patient that has few months to live, I may go with megestrol acetate because it does take time to work. But if I have patients who have few days or few weeks to live, then I might choose corticosteroids over megestrol acetate, considering the long term, considering the time, considering the side effect profile, and considering the cost as well. Cannabinoids is another option. They are well known to increase appetite, it's known as the side effects of cannabinoids. A synthetic agent include dronabinol, which is an oral capsule that's FDA approved for anorexia and weight loss in patients who have AIDS or HIV. There are some data that was published in patients with cancer, but showed that comparing megestrol to dronabinol, megestrol was superior. It showed significant better in terms of both stimulating weight and compared to using dronabinol alone. In dronabinol, even when we talk about efficacy, most of the efficacy again came only with AIDS or HIV patients. Very minimum efficacy, or the data is inconclusive when it comes to cancer patients. But if you have a patient that has HIV or AIDS and you decide you want to use dronabinol, the recommended dose is 2.5 milligrams per 2.5 milligrams once or twice a day, and you can increase it up to 5 milligrams once or twice a day. Anabolic steroids is another option. Testosterone and its derivative, oxandrolone, has been studied in patients who have HIV, AIDS, or type 2 diabetes, or end-stage renal disease, or COPD. But there's very, not in cancer, so just to think about who's really a candidate for these drugs. The Endocrine Society published clinical practice guideline for replacing testosterone in these type of patients who have chronic illnesses, with the exception of cancer. And what they found is that there is increase in lean body mass and increase in muscle strength. However, we don't have long-term data, and we don't have an established dose as far as if I'm going to give oxandrolone, what dose should I give and for how long should I give it. So that makes it a little bit like maybe not the first choice if you have someone who has cachexia, because we don't have long-term data as far as the efficacy of these drugs. So think about other drugs as first line versus this is more like a third or second line option for a patient who did not respond to Reversible or corticosteroids. Ciproheptadine, which is a histamine antagonist and has some anti-serotonergic properties, and have shown to produce slight improvement in appetite in patients with cancer cachexia. In clinical practice, we see being used for patients who have also HIV or AIDS-induced weight loss or anorexia. It has no effect on body weight, just like corticosteroids. And one of the biggest things about ciproheptadine and using it, and a lot of physicians are hesitant of prescribing it, the fact that it does cause a lot of sedation. So that makes it hard to prescribe it in someone who's elderly, or to prescribe it in someone who's functioning through the day, so going to work, and someone who's having activity day to day. It makes it hard for us to prescribe a drug that could cause potentially a side effect such as sedation. Mirtazapine is a tetracyclic antidepressant, which is FDA approved for the treatment of major depressive disorder. It's known, a side effect of known of it, that it does cause appetite stimulation, and it does cause weight gain as a standard treatment dose of 7.5 milligrams per day or 15 milligrams per day. It has shown, in compared to placebo, increase in appetite and weight gain compared to placebo. It was a study in a controlled trials. They compared mirtazapine to placebo, and they found that 17% of patients taking mirtazapine reported an increase in appetite compared to 2% of patients who received placebo. And even when it comes to weight gain, patients who took mirtazapine had increase in body weight by up to 7% compared to 0% in patients who took placebo. So not only it makes you feel the sensation of increasing the appetite, but it does also result in increase in weight gain. However, most of these studies came from geriatric populations, or patients who have depressions, or patients who have dementia with depressions. There is limited data when it comes to cancer-related cachexia, but it is an option, especially if you have patients who have depression. So you can give them one drug that will treat their depression and at the same time they're cachectic, or for patients who also have sleep disturbance, like patients who have insomnia of some sort. Mirtazapine is known as well to cause sedation. So that could be also another option for someone who has insomnia, and at the same time they have cachexia. That could be an option for them as well. Other drugs that could be used for the treatment of cachexia include thalidomide, which is a potent inhibitor of tumor necrosis factor production. It's been associated with weight gain in patients with tuberculosis or patients who have HIV infection. There is possible role in cancer patients, but the data is very inconclusive. There is insufficient evidence to support the use of thalidomide, and that is due to the fact that thalidomide has a high side effect profile. It causes peripheral neuropathy, it causes severe nausea and vomiting, it causes sedation, it causes thrombocytopenia, chronic use of it. So it really kind of limits its use in clinical practice. It's mainly only been studied in patients who have tuberculosis or patients who have HIV infection, and even in these patients, there wasn't a lot of data showing the use of the efficacy and to support the use of thalidomide as an option for patients who have cachexia. Amino acids, L-carnitine, which is an amino acid. In cancer patients, there are data showing that low serum levels of carnitine have been attributed to decreased caloric intake as well as diminished endogenous syntheses. So there are some studies that showed that L-carnitine supplement taking as much as 4 grams per day has shown to improve body mass index and improve the quality of life of these patients. There are also some data showing, in addition to carnitine, L-carnitine, in addition to Reversible, did improve the appetite, did improve the body mass index, did improve the quality of life. It is an option for some patients who may refuse pharmacological options, who only want to rely on oral supplements of some sort. There are some data showing that it does work. As far as long-term efficacy, we don't have data. The data is very inconclusive as far as how long should I use it and what's the effective dose. When you look at the studies, most of the dose is 3 grams per day. Sometimes it could be 4 grams per day. So you really have to decide on what you're going to do and if you're going to recommend this supplement for some patients and so on. Celecoxib, which is a non-steroidal anti-inflammatory, is another option for patients who have cachexia. There are a number of studies that looked at the efficacy of celecoxib in cachectic cancer patients. They found one study in particular. It was a placebo-controlled study. There was a pilot trial that looked at cancer patients who were cachectic, patients who had head and neck cancer, and they received celecoxib 200 milligrams per day, twice a day, and it was associated, compared to placebo, was associated with weight gain and increased body mass index compared to those who did not celecoxib. It is an option for these patients as well. You can consider it. One thing to think about is the cost. It is generic, but it's still expensive. One thing to think about also, if patients have any contraindication for receiving celecoxib, and we don't have, again, long-term data on efficacy of using celecoxib for patients who have cancer-induced cachexia. Other options is fish oil. The evidence for the beneficial effect of supplement omega-3 fatty acids on cancer cachexia is inconclusive. On cancer-associated cachexia, there was a Cochrane review, database meta-analysis that was done in 2007, and it concluded that there is insufficient data to establish that omega-3 fatty acid does increase weight, does increase appetite, and so on. This is important because in clinical practice, or even now, think about our palliative care patients. A lot of patients take supplements over the counter because where they see ads on the TV, or their relatives told them to take it, or they are under the assumption that it does work. This is where we come in as healthcare professionals, and to make sure that we provide the patient with the accurate information. So a drug like this, if a patient tells me, well, I'm taking it because it does improve my appetite, there's really no insufficient data showing that it does work. So it's our obligation to really kind of deliver this information to the patients and the caregivers, so we can reduce even, pill burden. They don't have to take a lot of drugs that is not providing them with any benefit. There is also, since the underlying mechanism, if we think back to the slide of the pathophysiology, since the underlying mechanism of cachexia is very complex, there is an argument that if you incorporate multimodal therapy targeting multiple underlying pathophysiology process, then in this way you can really hit different receptors, and you can get better efficacy and better outcome. The largest randomized studies that was done, it included 332 patients who were given either megestrol acetate, fish oil, thalidomide, or L-carnitine, or combination. So where they were giving either one of those or all together in combination. And what they found is in the combination group, people did better in terms of sensation of appetite. Their appetite got stimulated. Some of them gained weight, but they definitely had more risk for toxicities and adverse events compared to the group compared to the other arm who only got one drug. Future drugs, or more things that we're seeing now in investigational trials, there are promising results that have been seen with ghrelin, which is a growth hormone releasing peptide that induces positive energy and causes a lot of, there are some data showing that it does cause substantial weight gain after only 3 weeks of using this growth hormone. Some study also in cachectic patients with COPD suggest that wasting and improving body composition, function, capacity, and symptomatic augmentation of growth hormone does also improve appetite and weight gain as well. And some preliminary report of 2 large double-blind control studies also among cancer cachectic patients noted significant weight gain and clinically meaningful increase in appetite in these patients. One thing to mention that ghrelin is not available as of yet in the United States. We need more data in the future. These trials are still under investigation. There are phase 3 trials. Maybe in the future we hope to learn more about the role of growth hormone for the treatment of cachexia in chronic illnesses such as COPD and cancer and CHF. When it comes to nutrition, artificial nutrition support, while nutritional supplements might appear to be ideal to control or reverse malnutrition, there's no evidence that artificial nutrition, including hyperalimentation, prolongs life or improves function status and is not indicated. It's very, very important to know that there's no evidence, and to remember that there's no evidence of artificial feeding in the presence of an underlying cause that's irreversible. There are some exceptions to the rule, so if you have patients that have high-grade bowel obstructions or malabsorptions from an advanced cancer, these patients might, or if they have a good prognosis, they might benefit from it. Or if you have patients who have good functional status, or if patients have ECOG score of 2 or 1 or 0, they might benefit from it. But the data is very controversial. The data in other diseases is very controversial and it's inconclusive. So really you break it down if you're going to provide nutrition versus no nutrition, depending on the prognosis, depending on the goals of care, depending on the functional status of the patient, and where are they as far as everything in the picture. This is really what can help you decide what you're going to do for these patients. So we have here 2 cases that sums up everything that we discussed today, 3 cases in particular actually, kind of provide us with an overview. So case number 1, we have a 53-year-old woman with advanced hepatocellular carcinoma currently receiving oral chemotherapy. She's seen in your patient palliative care clinic today. Her pain is controlled, but both the patient and her husband are concerned that she has had little appetite and had lost 10 pounds since her last visit. She's still ambulatory and enjoying most of her former activities, but she misses the enjoyment of eating. On physical examination, you find that she's a thin woman with normal vital signs. She has no signs of candida infection, so the physician is doing a good job at evaluating if there's any oral problems happening that's resulting on the patient's not wanting to eat or decrease in appetite. He also examined for other lesions in her oropharynx. She has normal dentations, minimal ascites, and no lower extremities edemas. So of the following medication, which is the best supporting effectiveness in treating her anorexia and helping her gain weight? So if we look at the options that we have, this is a patient that has cancer. So option number 1, Dronabinol. As I mentioned, Dronabinol has very limited efficacy when it comes to cancer-induced cachexia. Most of the data came with patients who have HIV or AIDS, and so wouldn't really be a good option. Also, Dronabinol does have side effects such as hallucinations and drowsiness and sedation, so it's not something that I would recommend for someone who's still ambulatory, someone who still have a good quality of life, someone who's still functioning. It wouldn't be a good option. Dexamethasone, most of the data, and as I mentioned in my presentation, came from dexamethasone in cancer patients. It is definitely an option for these patients, but we tend to reserve more dexamethasone corticosteroids for patients who have limited prognosis due to the fact we do not want to put them on corticosteroids and then they develop long-term toxicities of corticosteroids. So although it is an option, it may not be the best option for her at this point. Maybe in the future, where at some point her disease will continue to progress, she might have limited prognosis, then it would be an option for her. Mirtazapine is another option. It could be an option for her, but we tend to reserve it more. The data, although some data showed that it does work, most of the data came from patients who had depression or patients who had dementia-related depression, and at the same time, the patient doesn't have, in an absence of depression, mirtazapine may be reserved. Like I would prefer to use it more in someone who has depression or someone who has insomnia problems or someone who has significant weight loss. I would prefer to do that. Then the last one is misoprostol acetate, which has the strongest evidence out of all of them. But before you decide, I'm going to prescribe misoprostol, few things to look at. Does the patient has good prognosis? In this case, she does. She's still ambulatory. She's still enjoying most of her former activities. She does not have a history of thromboembolic events, so she doesn't have DVTs or PE, so it would be a good option for her. She have long time. She's not someone who has few weeks to live. She probably has a couple of months, so it would be definitely worth it to try it. So the correct answer in this case would definitely be misoprostol acetate. Case number 2, we have GF, who is a 68-year-old woman with metastatic colorectal cancer who is receiving palliative care only. She reports a decreased appetite and the weight loss corresponding to 8% of her body weight over the past 2 months. In providing education to this patient about her condition and or possible treatment options, which of the following statement would be most appropriate? Is it A, cancer-related cachexia is associated with increased mortality, so she should try to increase her food intake? Is it B, it is likely that muscle mass in her body is declining, so she should consider hospitalization to receive parenteral nutrition? Is it C, most patients with advanced cancer who have decreased appetite and weight loss should receive corticosteroids such as dexamethasone? Or is it D, Majestrol acetate may increase her appetite but has not been associated with an improvement in survival? So let's go through the answers one by one. Answer number 1, cancer cachexia is associated with increased mortality. She should try to increase her food intake. Cancer-related cachexia can result in mortality, but it's not the main cause of mortality. So this is really incorrect. Oftentimes people are dying because of an irreversible underlying cause. And in her case, it would be due to the fact that she had metastatic colorectal cancer. So increase her food intake is not really going to do much for her at this point where she has metastatic colorectal cancer. She's losing significant amount of weight. It's not going to do much for her. So answer A would be incorrect. Answer B, it is likely that the muscle mass in her body is declining. She should consider hospitalization to receive parenteral nutrition. We talked about parenteral nutrition and we said that it's controversial. It's only indicated there's no evidence showing that parenteral nutrition is effective. It's only indicated for patients who have good prognosis or patients who have long-term before they expire or before they die. It's only indicated for patients who have bowel obstructions of some sort, and she doesn't have any of this, so that wouldn't be the best answer for her. Answer number C, most patients with advanced cancer who have decreased appetite and weight loss should receive a corticosteroid such as dexamethasone. That is a correct answer, but it really depends. It's not the best answer because it depends what the time frame is, and it depends if patients have contraindication for dexamethasone or not. So if you have someone who has severe OR candida and they have cachexia, I may not recommend dexamethasone for them because it's not an option because it will worsen their OR candida. And it's not mandatory that they should be recommended for everybody who has advanced cancer of some sort. But it is an option for someone if they meet the criteria for indication for corticosteroids. D, Majestrol acetate may increase her appetite but has not been associated with improvement in survival. That is a correct answer because, as I mentioned in the presentation, Majestrol acetate, although it does cause patients to have increase in appetite, increase in weight, specifically water weight and specifically fat weight, it has not been shown to improve survival at all. And even it does take time again, like I mentioned, it does take 8 to 12 weeks to see even benefit of using Majestrol acetate. We have one more question. Majestrol acetate is associated with which of the following side effects? Somnolence, constipations, drowsiness, thromboembolic events. Let's go through the answers. It does not cause somnolence. It's actually quite the opposite. It does cause insomnia. It's one of the main reasons we tell people take it in the morning. It does not cause constipations. It does not cause drowsiness. The correct answer would be D. It does cause thromboembolic events, and it's oftentimes dose-related. The higher you go up on the dose, the more likely you will see these side effects. And this is very important if you have patients who have DVT of some sort or PE, or they have a coagulopathy problem, is to really try to avoid Majestrol acetate as much as you can in this patient population. So in conclusion with today's presentations, cachexia is a core clinical features of many advanced illnesses. It's something that we see in many chronic illnesses, including cancer, COPD, CHF, dementia, and so on. Cachexia too often goes undiagnosed or untreated with adverse consequences for the patients. As I mentioned, it's a silent symptom. Patients sometimes are not necessarily going to complain about it, and it has a very negative consequences on the patients and the caregiver, and it does impact the quality of life. So it's something that we want to try as much as we can, effort to assess and treat with pharmacological options and non-pharmacological options. Feeding is not the answer, especially with advanced illnesses. These are where we have meaningful discussion with the caregivers, with the patients, with the family, focusing on goals of care, focusing on what matters now, focusing on addressing non-pharmacological options for these patients rather than just the fact that we want them to eat, but then there's no benefit. We might actually be causing more harm than benefit. Pharmacological options are available but require a risk versus benefit assessment. We discussed a couple of pharmacological options today, but every time you think about prescribing one of those drugs, you really have to think about the risk versus benefit, taking into consideration cost, how long does my patient have, function status, prognosis, availability, ability to take these drugs, and so on, even side effects profile of these drugs and long-term efficacy. So now we're going to be having some question and answers, so I'm going to give you 1 minute to gather your thoughts and to post your questions. So the first question that we have here is, would appreciate thoughts about efficacy of appetite stimulant with my hospice populations. So as I mentioned today in the presentations, the efficacy of these drugs varies depending how long do you have for the patient and depending where your patient is at. If you have a patient that has more than 12 weeks to survive, and if they have no contraindications, I would go with first would be misoprostol acetate if they have no contraindications such as thromboembolic events or peripheral edema or congestive heart failure and so on. That would be one option. If you have a patient who is hospice but on the same time they have a limited prognosis, but you do want something that stimulates their appetite a little bit, gives them that sensation of wanting to eat, then I would go with dexamethasone or any of the corticosteroids as an option for them. Mirtazapine is another option. The efficacy again is, very inconclusive in the sense of like which one should I recommend over the others. But I would stay within those three first. I would stay with misoprostol acetate, steroids, mirtazapine. I could even go to cyproheptadine if I don't have patients who have, if they don't report sedation and so on is another options. Others that we discussed in the presentations, the data, as I mentioned, is very inconclusive. We don't have long-term efficacy and benefit showing that they do work. So you really have to be selective of what you recommend for this patient population. We have another question here. What is the recommended dose of dexamethasone for cachectic patients? So we don't have a specific guideline that tells us the effective dose for the treatment of cachexia with corticosteroids in general. But when you look at the trials, most of the dose that they were using for dexamethasone was about 2 to 4 milligrams per day for as long as 2 weeks for these patients. So that would be my starting dose for these patients, 2 milligrams to 4 milligrams per day. We have here another question. Which patients would you suggest the use of NSAIDs and MAGAs? So if I have a patient that has an inflammatory pain of some sort and at the same time they're cachectic, these are the patients that I would recommend because I'm hitting two conditions with 2 drugs, but at the same time I'm looking to see I'm looking to see both benefits. I'm looking to see benefit as far as pain relief. If they have like bone pain, for example, and they do need NSAIDs and at the same time they have cachexia and they need something for the cachexia and they have no contraindications, then I would recommend these 2 drugs for them. That would be an option for these patients. We have here also one more question. Is the recommendation for administration of MAGAs to administer for only 8 to 12 weeks or for at least 8 to 12 weeks before deciding if it has benefit? The recommendation is to try for as long as 12 weeks. So if you have a patient that you started, but if you started right now, it's recommended to go all the way to 12 weeks. But if it's been 8 weeks and you're not seeing any benefit as far as appetite stimulation, as far as weight gain, you can decide at this point. You don't need to go to the full 12 weeks. You can decide if you haven't seen any benefit by 8 weeks, you can decide and say, I'm going to stop this drug right now because I'm not seeing any benefit. I'm going to think about other options for my patient at this point. But it is recommended to go to 12 weeks if you're seeing benefit, to go to the full 12 weeks if you're seeing benefit. That's it for questions. Thank you so much for the presentation today. I hope you enjoyed it. And I would like to remind you for our next webinar, which will be on music therapy strategy for symptom management by Dr. Lucian McGill on May 14th at 12:30 p.m. Thank you and have a good day.